So I guess, I'm not even really sure what the difference between palliative care and hospice care is.
Okay. And that's, obviously a huge question for most people. They don't even understand or know what it is. But I think one of the easy things that I like to say first is, so all hospice care is palliative care. Our goal is to palliate symptoms, right? Keep people comfortable. But all palliative care is in hospice. So there's a great definition on that one slide that you sent me down here about, palliative is for anybody suffering chronic severe illness that causes symptoms and that they need, an extra level of support. So we do clarifying their goals about how aggressive or limited they want their care to be, and then palliating any distressing symptom burden, whether it be dyspnea, pain, or nausea, vomiting, or just, again, the psychosocial, emotional, side of the support through it. So anybody can have palliative that is going through something like that. Great example, right? Patients with cancer that are still getting chemo,
Okay.
They're still seeking treatment, but there's a lot of symptom burden going through that. And so palliative care is a great service for them. Specifically in the hospital, and even the clinics, usually you have a social worker or sometimes a chaplain, so they can get that support with palliative care. The difference comes with hospice is when you have that illness that is life-threatening, the prognosis is 6 months or less, and the focus becomes comfort, palliation of symptoms without curative treatment.
Okay, so the destination is we're expecting within 6 months this person's going to die.
Yeah. And that's where a lot of times, before I even did hospice, I was surprised that people got discharged from hospice. When I started doing it, I was like, oh, we discharge a lot of people because, your folks with COPD or Alzheimer's, they have a long clinical course and they may be declining, right? You're like, they're still kind of declining, a lot of these Alzheimer's, but do you think they're 6 months? No. Where families are struggling a lot with those changes and that decline and all the support they need and all the new help. But I don't think they're, not going to be here in 6 months. And so sometimes, we have to, somebody with Alzheimer's may have, gotten in really bad shape after they've been in the hospital a couple times with UTIs, and then family gets them home, hires some paid caregivers, figures it out, and they perk back up. I'm like, okay, now they're maybe not so hospice appropriate.
Well, that's kind of important for us to know too, because I guess if we get called to them, it's just because they're on hospice doesn't mean that they won't be, I guess, discharged from hospice.
Yeah. We've had some people that they do better. Right? Because we come in, we get aides in, you've got a weekly nursing visit, the aides come out 3 times a week and help them bathe, and you know what I mean? And we just help with some of the services, get people Meals on Wheels, and then they do bounce back, and you think, okay, well they're actually doing better than before. So it's possible.
So I guess our protocol is probably more applicable to the person who's actively dying.
Yeah.
Like they're within, I don't know, when does that process start? What's
the definition of actively dying?
Yeah,
that became so controversial during COVID, right? Because our visitation policies were so strict, and the hospitals were like, well, we can't let family be in unless they're active. And you're like, okay. But should you not let the family come in and talk to them while they're still awake?
They can comprehend.
Exactly. So it is hard because, it's hard to nail down a definition, and I feel like I always feel bad, like I'm fudging for people. But we always tell folks in ranges. So when I give somebody a prognosis, just like when they get their cancer prognosis, and somebody says months, but then you see changes, and then we'll go weeks to months, days to weeks, hours to days, minutes to hours. So that's how I always tell people, because, right, every individual person, I'm going to see somebody and I will swear they're not going to be here tomorrow, and they live for, 3-4 days, and then I might walk out and I think, oh, they're going to have a couple days, and they pass that night. So it is an art to try to, but, a lot of those specific questions, like you said, the changes that when you hear from a family, well, they're not able to even swallow now. They haven't had anything to eat or drink for days. They're pretty much only sleeping. When does it come that they don't even wake up anymore? And then, like you said, some of the exam findings, like, are you seeing those circulation changes where they're starting to have cool extremities or modeling? Their breathing pattern, are they more erratic? Then, when you start to see the modeling, those breathing changes, that's when you're like more into, I'm thinking, hours to days now. Active is what I call it that.
Hours to days. So, like, when would you say the vital signs really start
telling you?
And
it's really hard because I've seen people, when they're still on the monitor, I mean, you'll see somebody with normal and they may just drop, or they may have up and down variability and then drop, but you don't always see that. So even in the hospital, when we take over somebody's care with hospice, we do turn the monitors off. We don't actually go by their vital signs. We tell the family, we're not treating numbers. We're going to look at them. We're going to look at their exam. We're going to look at their comfort level. And so, I mean, the tachycardia can tell you sometimes, if you have severe tachycardia or severe bradycardia, then you're like, okay, there's changes. I still listen to people every day. Are they irregular and they weren't yesterday? Or is there a big rate change? But I'm not defining it based on like a certain rate. It's more honestly like comparison. If they've been tacking along and suddenly it drops, or they, are irregular now, that kind of stuff. And then again, just listening to that chest, are they starting to get new congestion, rattling secretions?
Otherwise known as the death rattle.
Yes, yeah.
For us, since we have to monitor vital signs basically constantly, instead of maybe turning it off, would you say maybe just silencing it and turning the screen away from families would be appropriate? Yeah, because again, a lot of them, they want to stare at it and say, what does that mean? And you're like, they could still be here tomorrow with those vitals. Like, we've had people with SATs, we admit them again and their SATs are in like the 60s or 70s and they're still there the next day, because when we give them the opiate, when we give them like morphine, their SATs might actually come up because I feel like they relax, right? Like the body relaxes and they actually breathe easier. And
so the SATs come up.
Yeah, I've had that happen. And like, we had somebody in the ER one time that didn't have a bed to go to, so they had to stay down there. The nurse was just like beside herself because she was like, I can't give, morphine right now. And I was like, you can. This person's breathing like 40 times a minute. Like, she's dying anyway. She's not comfortable. Like, we're not going to kill her with this because look at her right now. She's dying. And we gave it and her SAT came up, because again, I think it's like, obviously, if you give high doses, we suppress respirations, and that is part of treating the tachypnea. But I think also if you give enough for that comfort, you're relaxing the tensity and when people tense up and they're breathing hard and they're anxious, when you relax that, they actually oxygenate better because, the physiologic changes in the body allow that.
Is that the opposite of everything?
Everything. Everything's kind of dose dependent. I mean, that's how families that. I'm like, obviously I can come in and knock people out, and make them comfortable that way, but that's not my goal. My goal is to bring them comfort of their symptoms, and whether they're at a point where that means they have to be sedated or they can be awake, again, is that individual person's.
Just to clarify, you're just saying just to make them comfortable, not to hasten anything along.
Exactly. And that's where, again, like you have on there, start low and go slow. But I mean, when you see sometimes even these little 90-year-old ladies who are opiate naive, and you think, okay, I'm going to start them with 2 of morphine, and it doesn't touch them. I mean, you still probably end up going, but you know that you've done your due diligence and that you just didn't come in and give them 10 right away,
Right.
which is, reasonable. That might be what they need, but you always want to tell, everybody, I didn't come in and just euthanize them. I came in and I'm getting them comfortable.
We're not we're making them comfortable. We're not we're helping the dying process in terms of relieving comfort, but we're not speeding it along, so to speak. Do you give them oxygen if the sats are low?
So not necessarily. Again, I'm a little nuanced in that. Like, I feel like COPDers, people with chronic lung diseases, I think that's a comfort to them because they're used to
Air on their face.
Right. So I'm more liberal with it. But if it's somebody that's not typically on oxygen, that's a little short of breath or tachypnic, we try to use the medication more so instead of looking at that number of the SAT, like you said. Because again, you've probably seen somebody with a SAT of 95%, but they're working hard, right? They're like super tachypnic, they're breathing like crazy, and you're like, their SAT's okay, but they're going to wear out. And you're looking at them clearly not comfortable versus somebody that's 86%, but they actually look okay.
Yeah.
So it's just, it's just a different way to kind of look at it. So our goal is not to escalate oxygen, but it's not like we never will.
Well, I mean, we're not trying to normalize their SpO2 because people's SpO2 drops when they're dying.
Yeah, but exactly. It's like it is in that, can we sort of prolong, like you said, I'm not trying to hasten, but am I going to prolong the dying process if I give them oxygen that they they don't want it prolonged, right? Now again, sometimes family will say, well, we're just waiting for so-and-so to get here and they want a little oxygen on there. Then of course we're going to do that. Like you said, you want to do the right thing for the patient and the family.
Yeah, that makes sense. Yeah. I didn't think about that. And we watched a webinar where they said, we don't give them oxygen, but we'll maybe put a fan on their face.
Yes, and I was going to say that. Like, we use fans a lot for that feeling, like you said, of some air where you're not necessarily giving them oxygen. But, some people have differing opinions on how much it might prolong things. But, I mean, I've noticed sometimes if we just leave 2 liters nasal cannula on somebody and then we do finally take it away, that they kind of go on.
Oh, okay.
Once the family's ready for that. So
that's interesting. Mm-hmm. So when do you decide to? So I guess you give opioids for pain, and then opioids for respiratory distress. Mm-hmm. So we're pretty good at giving it for pain, like we do that all the time. But when we hear giving opioids for respiratory distress, it raises some red flags. But how do you decide when to give opioids? Do you look for tachypnea, gasping?
Yeah, just like I was saying in that example, when you're looking at somebody and clearly they're in distress and they're tachypnic and they're uncomfortable from their breathing, if their goal is comfort, if they're not wanting aggressive life-prolonging treatment, then that's when you're going to turn to it instead of the normal things that we think of oxygenation, of oxygen support. The respiratory rate, accessory muscle use, the gasping, people that tripod or purse-lip breathe, those kind of things.
You start low and go slow. I like that. And the vital signs should initially, when we're talking minutes to hours, you'll see tachycardia, tachypnea, hypoxia, gasping, and that's all just a normal part of the dying process.
And like you said, like, gasping sounds very like a negative term, so you hate to, like, you do want to treat that. You don't want people to look like they're gasping. Again, that accessory muscle use. But sometimes when I watch people, you're trying to educate family what would be normal. Like, okay, you can see their breathing is different, but they're not actually distressed. And, sometimes people have like that kind of guppy breathing,
Uh-huh.
or they'll jaw thrust or tongue thrust even.
Oh, yeah.
But I tell people, the difference for me of if this is kind of normal, relaxed, end of life breathing versus when they're distressed is, everybody's kind of extends their neck too. That's normal. But are their shoulders like lifting or pulling forward? Or is it very like isolated kind of movements in there? If they're using those shoulders, like I said, all that accessory muscle, or even lifting their head up, that's when I get like, I think they need the medication to kind of make this a more comfortable.
That makes sense.
Mm-hmm.
And and we give opioids for pain. So how do you determine if they're in pain, if they can't vocalize it?
Right. And again, it's hard. You have to look at all those nonverbal signs. Like we talk to people, families, okay, their baseline. So is their brow furrowed right now, or do they have those little lines normally? But again, the brows, like the forehead wrinkling, like you said, just a nice grimace, like you can tell. Or, sometimes even to me, what I look at is their face just look tight, because everybody that's relaxed, their mouth is going to drop open, and, that breathing is open-mouthed, and the face should look relaxed. Now, if they're, it's just like if their mouth and jaw are tight, then I'm kind of too, I'm like, I don't, I'm just wondering, are they quite there yet? Or again, just with movement, do they seem not just restless, but specifically, like you said, tight posture, or anything you do, like when they're getting care, like if they're getting turned or cleaned up, from personal care, are they just moaning and groaning and grimacing with that stuff? Then because I do. A favorite thing I like to say to people again is like when somebody becomes bedbound at the end of life, if they've been in that position for hours to days, I'm like, think about yourself. If you slept in that same position, like your body's even just tight and achy now from that alone, even if you didn't have any other specific pain from your terminal disease or from arthritis or something.
You now have pain from that.
Yeah.
From not moving. And I guess I was thinking we could maybe use vital signs for pain. Your heart rate would increase blood pressure, but also you don't know what trajectory they're on in their dying process.
Right.
Because it goes up and down.
Right. So they may be tachycardic just because they're dry now. You don't know. But like I said, I have the advantage a lot of times of knowing some of the day-to-day or like recent history to know whether that might be the case, but like I said, because when it's a change is when I know. But yeah, having a isolated set of vitals is sometimes very helpful. Yeah. Like you said, well, if they're 30% and their heart rate's like 30, you're like, okay, they're right there. But
I guess that's why it's important to get you all on the phone, because we often get called for complaints, I guess because the families, they see a change, could be a normal expected change, but they kind of panic.
Yeah.
Or do they get a comfort pack? I've heard that term used.
Yeah, so that is a very common thing with hospices to have comfort kits. Now, our organization had them in the distant past, and then again, legally, there got to be some controversy over whether that was nurses giving orders instead of coming from physicians. But we have started to work on that. So we don't have them right now, but we've started to work on that because we look at other organizations. There's other hospices in Kentucky that have them. Specifically, our organization has coverage area in Northern Kentucky, and St. E does too. So kind of like our competitor, well, they do them, and we're like, well, how could they do them, and we're not allowed to.
Is it like an emergency kit?
Yeah. So the goal again that we're working on is for it to be when we admit patients that we think may be pretty close to being end of life, and maybe, pharmacy coverage in that area is not, there's no 24-hour option. Again, we have Hazard, we have Corbin, we have
some rural
areas. Some northern Kentucky places where the nearest 24-hour pharmacy is going to be an hour away.
Oh, okay.
So we're working on a kit that would have, say, an opiate in it, and probably it's going to be like morphine concentrate, and then maybe things like some Tylenol suppositories, some Levsin for secretions. I believe like a couple tabs of Ativan. So it's going to be like a very small amount. For that. In the middle of the night, you have no other option to get anything. Otherwise, our goal is to, like if we admit somebody on a Thursday and we're like, I'm like, do we need to go ahead and get some meds in the home because the weekend's coming up? Even if they're not truly symptomatic right now and we don't feel like there's any concerns with family, then we go ahead and try to have meds in the home.
Is the comfort pack also for like when you did it and when you're going to do it, would that also be for breakthrough pain? And I guess, like, how do you define breakthrough pain? I guess if they're normal regimented pain medication, like it's working for them and then it stops. It's no longer controlling the pain.
Yeah. I mean, we always, even when we have people on long actings like fentanyl or morphine extended release, they're almost always going to have like a breakthrough short acting, unless they're just a patient that has some sort of history or diversion, has happened in the home where we're being more strict on, okay, we're going to give you fentanyl and that's it.
That makes sense.
Yeah. But those comfort kits, again, like we're working on getting them back, but they will actually even be something like our pharmacy will send, and they'll be like sealed that the patients or the families won't even be the ones, like they won't open them until like we kind of authorize it as well. Like they're still going to call and have the conversation about, okay, this is the time, go ahead and open it.
That's smart.
Yeah.
In the event that we get called out to help them, would we be able to access that? Because from what I understand right now, if they do have a comfort pack, EMS isn't allowed to even really look at it. So
yeah. Well, again, that's our goal, is to be like, it's there for the availability when it's needed, but it's not just an order of hey, give this morphine anytime you need it right now. Does that make sense? Yeah, like you're still going to call the doctor and get that order to, okay, let's open it and utilize it.
absolutely.
Yeah. So, I mean, like you said, you all were there. I mean, a lot of the stuff that I was thinking, like, it's time dependent, but if you could call and like, you get orders real time.
I mean, with that, our protocol is fentanyl because that's what we carry. But morphine would probably be better because it's longer acting than most. It'd be better for most patients, I think. And our goal, isn't to operate in a silo. Like, we don't want to be the ones making these decisions.
Yeah.
But we want to be able to facilitate and help. Like, if the family calls 911 with the goal, if they call 911 and it's related to the end of life and their goal is to not go to the hospital, we want to be able to help, educate and have a pathway to leave that patient at home.
Yeah, because they're looking to you for that guidance.
Yeah.
Absolutely. I mean, this is what they know. They're used to calling 911. They're used to having that help. And sometimes, it is true. Like you said, staffing just has limited us sometimes with, getting those phone calls right away, getting a nurse out there. Like, the ideal world would be.
And most of the time, we're getting the calls at night.
Yeah.
I don't think you all staff 24 hours, do you? So.
We technically do have nurses on call all night, but it's the number of, there used to at least be 2. And then now, I'll just be honest, staffing with ambulance transport, like I feel like people come home from the hospital, they're all coming home at like 8, 9, 10 o'clock. So, it's hard because then our nurses are out there like doing admissions at that time of night where, ideally you wouldn't have that. They would just be on call for the existing patients that need things. So it is a staffing thing where it's like, well, I'm going to call 911 because I know I'm going to get more immediate help.
Yeah.
And like you said, being able to direct them and to kind of support. Because I've heard that story before. Like, I mean, I've heard great, people come out and they've helped them. They've fallen off the toilet. They've fallen down. You get them back and you're kind of like, well, they don't really want to go to the hospital. Like, they just want to stay at home and be comfortable, but they needed some help. And then I've also heard the paramedics told us if this was my family member, I'd take him to the hospital. And you're kind of like, and they were, like you said, they're doing the best that they think in that situation. Yeah. But I think, even throughout all your questions, you guys highlight that of saying, like, let's emphasize, like, what was the reason you called? Because I say that to the people in the ER too. Like, why are they here? Are they just scared and they don't know how to deal with this on their own? And this is kind of the normal that they're always used to. And they don't really even, they don't want aggressive treatment. They just want reassurance, direction, and their loved one to be comfortable right now. And, what can we do to make that happen?
And I think we have to, this is just it's not the same patient we're used to caring for. Mm-hmm. You call 911, we come, we treat your symptoms, and we transport you. And so we're really gonna have to do some investigation, like, is this complaint related to the dying process? Because I suppose, in some situations, taking them to the hospital might be palliating. So if they fall, break their hip.
Yeah. Broken bones are the best example. Like, we say that for like nursing home patients all the time. Family will say, well, we don't want hospital transport unless like they've broken a bone and it's clearly excruciating or sticking out like that. It just needs to go, right? They're not going to be comfortable with that versus, I have a hard time with the best example. But say somebody's got end-stage heart disease and that's why they're on hospice, but then they start having a GI bleed. Well, it obviously relates to their prognosis of mortality, but it's not exactly the same, right? It's not the same disease process as their heart failure. Do they still want to go to the hospital and would they want to be scoped? Do they want blood? Do they, those kind of things? It's kind of like, it's not exactly the same as their terminal diagnosis with hospice. So they might want to go to the hospital for that, whereas they were kind of on the page of, well, I'm not going back to the hospital for heart failure exacerbations anymore because this is my life. This is,
there's nothing else they can do for that.
Right. And it's a different story, right? Whether they would be a candidate for things for a GI bleed, but it's just kind of an example of, the differences with, like, I may get complicated, but people with dialysis and, can you have hospice and dialysis? And typically it's like, well, that's pretty aggressive life-sustaining treatment.
Yeah.
Obviously, if your terminal diagnosis is your kidneys, but what if you have pancreatic cancer and you've been on dialysis? Well, I'm like, honestly, if you keep doing dialysis, it doesn't matter. You're going to die from your pancreatic cancer pretty quickly, right? So we've taken people on, say, with a cancer diagnosis that are still getting dialysis, but they can still transport. They can still go to their dialysis. They're getting out of the house. And at some point, that becomes a problem and it resolves itself, that they can't go to dialysis anymore. So then they stay home and pass from their cancer. But like you said, there are some sticky, thinking about what's related to the terminal diagnosis and not.